In hospital corridors everywhere, a distinct patient population is caught in a relentless cycle of blood draws, clinical exams, and heavy diagnostic machinery. Between 1 and 10% of the general population is locked in this intense pattern of healthcare utilization, remaining symptomatic for 6 months or longer. Historically, the medical field grouped these patients under the label hypochondria, an obsolete catch-all term that obscures the clinical reality. For this specific group, standard medical intervention creates a paradox. The standard protocols of care are actively causing harm. The specific act of delivering a negative test result and offering a clean bill of health is iatrogenically counterproductive. To resolve this, we have to discard that monolithic label and look at the precise bifurcated diagnostic model recognized today. We must map the behavioral phenotypes, dismantle the medical reassurance trap, and construct a coordinated clinical pathway. Understanding this iatrogenic paradox is the only way clinicians can intercept these patients and stop an endless, costly cycle of unnecessary care. Both of these modern conditions share a strict baseline requirement: severe health-related anxiety persisting for at least 6 months. This decision tree maps the bifurcation of these diagnoses. The left branch maps illness-anxiety disorder, or IAD. IAD is defined by a severe preoccupation with having a serious illness, despite the patient possessing minimal or absolutely no somatic symptoms. The right branch maps the second condition, Somatic Symptom Disorder, or SSD. SSD is characterized by high anxiety that is distinctly driven by the presence of one or more actual bothersome physical symptoms. While the internal diagnostic criteria differ, both disorders generate specific, observable outward behaviors. The first behavioral output is avoidance. Here, the patient actively skips medical appointments out of sheer fear of what might be discovered. The second behavioral output is excessive health checking. This patient constantly researches symptoms online and repeatedly seeks clinical exams. It is this checking phenotype that primary care clinics and emergency systems encounter most often, flooded by visits that yield no physical findings. Distinguishing these specific phenotypes is critical because the checking behavior triggers a hidden failure point in standard clinical workflows. Consider a checking phenotype patient presenting to their primary care provider with acute anxiety over a perceived symptom. A physician's ingrained training is to investigate the complaint, run the appropriate diagnostics, and comfort the patient with a negative result. This circular feedback loop maps how that instinct backfires. It begins when a perceived health trigger causes a massive spike in the patient's anxiety. In response, the patient escalates their care. They actively seek specialist consults or advanced imaging to resolve the fear. The physician intervenes by delivering a clean bill of health and verbal reassurance. This produces an immediate but deceptive result, a brief temporary drop in the patient's anxiety levels. Then the system fails. The patient's tolerance for uncertainty drops, causing a severe rebound spike in anxiety that closes the loop. In this cycle, the physician's reassurance is the actual catalyst that guarantees the loop will repeat. Psychologically, the reassurance functions as a short-term compulsion. By satisfying the immediate urge, it strongly reinforces the long-term obsession. The systemic fallout is massive. Patients endlessly cycle through multiple specialists and advanced imaging suites without ever resolving the root symptom. By attempting to cure the patient's fear through repeated medical testing, the healthcare system is actively fueling the underlying pathology. Breaking this reassurance trap requires a complete halt to the endless cycle of diagnostic testing. The evidence base supports cognitive behavioral therapy, specifically structured for health anxiety, as the first-line treatment. Clinically, CBT is frequently augmented with SSRI medication to manage the patient's underlying neurochemical anxiety baseline. Mechanically, CBT works first by safely exposing the patient to their specific health-related triggers. Simultaneously, the therapy actively trains the patient to stop their reassurance-seeking behaviors entirely. However, clinical resolution is impossible if the patient can still extract medical reassurance from their primary care provider between therapy sessions. Structured CBT's efficacy relies completely on removing the patient's escape valve, meaning the endless loop of medical testing must be shut down. Implementing this requires a structural shift. Primary care providers and therapists must establish direct, coordinated communication. This architecture diagram illustrates the optimized care model built on two aligned pillars: structured CBT on one side and coordinated PCP communication on the other. The primary objective of this coordination is to enact strict, unified limit setting on all future diagnostic testing and specialist referrals. We recognize the administrative friction primary care providers face when trying to find specialized, accessible therapy networks for immediate patient handoffs. Specialized referral networks, such as coping and healing counseling, provide the practical solution for systemic implementation. CHC operates a frictionless, 100% HIPAA-compliant telehealth model serving all 159 Georgia counties, with a diverse team accepting major insurance, including a $0 copay for Medicaid. Shifting a patient from uncoordinated medical reassurance to a unified, limit-setting behavioral pathway is the definitive way to resolve the health anxiety utilization crisis.